And we have with us today Dr. Bronson. I actually watched some of your videos on TikTok. Um, Learned a lot of stuff about TRT. I'm obviously somebody that is on TRT, so I'm very interested. I have plenty of clients that are on TRT, so I figured we have a whole bunch to talk about. Thank you so much for coming on the podcast. It's great to have you on.
Yeah, my pleasure. Thanks for having me.
Perfect. So, Dr. Brunson, first thing I want to talk to you about, and I'm going to go, it's kind of like a personal question that I have, and I'm curious your opinion on it. Between cypionate and enanthate testosterone for testosterone replacement therapy, I've had a few guests on. I've heard some difference of opinion. I'm curious what your opinion is of
The difference in terms
it.
of,
And which one would you prefer for patients that are on TRT?
I prefer testosterone enanthate because I try to get people to inject it subcutaneously, and there's studies showing that testosterone enanthate sub-Q has the least amount of side effects when you compare it to test C sub-Q or IM or even test E intramuscularly. So that's what I prefer. But I think they're basically the same. I mean, I don't think one is more effective than the other. It's just maybe slightly, when you give it to people subcutaneously, I think test E has slightly superior outcomes in terms of specific side effects.
I'm curious about that. How come? Because I've actually heard the opposite. For most of the doctors that I've spoken to, they recommend intramuscularly. Some of the reasons they give me is the crystallization of the testosterone, anything like above 100 milligrams, for just the amount of oils into the fats. That it's more direct, less chances of having those like the little lymph particles where you start getting like the little swelling in the fat from the sub Q injections. They said that happens more frequently because I wanted to do it sub Q originally just because shooting intramuscularly is just an unpleasant experience. What's your? I'm curious why you like sub Q more.
Well, when you get commercially available test C or test E, it can come in a carrier oil that some people have hypersensitivity reactions to if they inject it sub Q. It's pretty rare that that happens, but it does happen. I think the reason for that is commercial test C is mostly prepared in what's called cottonseed oil, and then test E especially is prepared in sesame oil. And sesame oil for a small percentage of patients can cause like irritative reactions, but it's mostly very well tolerated. I mean, there are studies, the American Journal of Urology 2021, if people want to look it up, was a study by Choi, CHOI. And again, that's 2021 Journal of Urology, where they compared the outcomes for men treated with IM test C versus sub-Q test E, and the sub-Q test E had lower side effects. It wasn't more effective, but it produced a less significant degree of, the main thing was erythrocytosis, so red blood cell counts go up when you're on testosterone. Doing it sub-Q may be superior for that. When you inject testosterone subcutaneously, most of it goes into the lymphatic system, as opposed to in a muscle, the oil forms what's called a depot. So what you're describing as nodules, it's really just the oil droplet itself. Wherever if you inject it sub-Q, you can feel it more readily because it's more close to the surface. But that's what it does, in the muscle too. So when you inject it into the muscle, the rate of absorption into the circulation is heavily dependent on the activity of that muscle. So a lot of guys do IM injections into their glutes, all right? And if they have a lot of activity with that particular muscle, it can speed the absorption rate, and that's what causes your levels to shoot up and give you what are called peak to trough effects. So most side effects of testosterone don't necessarily come from your testosterone levels being high or your estrogen levels being high for that matter. They come from more so the rate at which they go up. So if it goes up really fast, that can cause side effects. If it goes down really sharply, that can cause side effects. The nice thing with sub-Q is you get more stable, steady absorption that's not dependent on what's called extrinsic pumping. So in skeletal muscle, particularly large skeletal muscles, your muscle activity actually, it's called extrinsic pumping, pushes on the blood vessels, and that has a pharmacologic effect on how fast things get absorbed. Whereas subcutaneously, some of it goes into the circulation, but more of it goes into the lymphatic system, and so you don't get huge swings. And after about 2 months, whether you're on test C or test E, and you get to what's called steady state, that ends up having your levels just be more smooth and cause less side effects. So that's what the studies have shown. There's not many studies on that. No study shows it's more effective per se, but just slightly less side effects. That's why I prefer it. But I don't. For example, if I have patients that come to me that have been on test C for years and they've been doing it intramuscularly, I don't. If there's no side effects, I don't switch. I don't change anything up really. It's just more if you were forced to make me choose, that would be what I would choose is test E subcutaneous.
It's,
Like
I'm curious.
crystallization, you're saying something about crystallization. Um,
Yeah.
yeah, so I mean the testosterone oils don't crystallize unless they're at low temperature. I mean, injecting it into your sub-Q fat's not going to crystallize it. So
Okay.
I don't know where that comes from, but um, yeah, I mean, you inject it sub-Q, then it's pretty much the oil is exposed to your body temperature, which is going to be more than enough to keep it from crystallizing.
Okay. Well,
So
that was just something I was told, and I was like, okay. As I really wanted to do it subcutaneous, they also told me that the doing it subcutaneous, I would probably have to cut up the dose. So I essentially take 100 milligrams of testosterone per week. I take 100 milligrams per week. And they told me that that would be better if I was going to do it subQ to do it in two separate doses, just because for the actually the amount of liquid that you shoot into the belly fat. I don't have a lot of stomach fat to shoot it
yeah, me
into.
either. Me either. So I do it into my upper inner thigh. Um,
Okay.
like I said, people who are doing IM injections that don't have side effects, there's no real reason to switch. It's fine to do testosterone injections IM. It's just it's just there's good evidence that doing it sub Q you can get less side effects. So for someone who's never been on testosterone, they're just gonna start testosterone for the first time. It's they probably will get less side effects if they do it sub Q. And the other thing, it's also easier to teach people how to do
Yeah.
subcutaneous injections too, and they're less
It's,
painful, they're less cumbersome. But
I feel like that's a huge deal is how much less painful it is because doing intramuscular injections on yourself, some people are less squeamish than others, but I've seen like a lot of clients like they'll literally have to call me on the phone, even though that's not my specialty. They'll come back. I'm super nervous. I'm like, well, have you talked with your doctor on how to do it? And they're just so nervous of getting the needle in. And it's like, if they could do it sub Q, that might be that's a much easier option. It's easier teaching to do it. Like you could do it when people do it with GLP-1s. Like it's absolutely nothing.
yeah, well, there's actually one study that looked at guys who were injecting into their glutes. They're doing IM injections, but they did MRIs on them and checked the depth of the muscle and the length of the needle they were using. And something like better than 50% of them were unknowingly giving themselves subcutaneous injections. So even a lot of people, guys who give themselves IM injections, actually probably are unknowingly giving themselves sub-Q injections. I mean, and there's no problem doing that, but that's why I tell people it doesn't really. matter the length of the needle they use into their glutes, because if it's a sub-Q injection, it's a sub-Q injection. That's fine. But as far as people being afraid of needles, I have an initial reaction to that. But
Yeah.
yeah, I mean, it's just easier to do it sub-Q,
Yeah.
to teach people how to do it. And the needle length is very tiny. Some people use an insulin needle, a 30 gauge or 31 gauge needle, which is extremely small.
You don't even know.
But I think it's better to use a 27 gauge half-inch needle. That's also very small, but it's easier to push out a very viscous oil if the needle is a little bit, smaller gauge, or the gauge size, the lower the number, the bigger it is. So I just think it's easier.
Yeah, for intramuscular injections, I found that the 23 gauge is like the good spot of like it pushes the liquid out quick and the oils out quick enough that it's not like you're sitting there trying to force it through. And at the same time, it's not like a big thick needle that you're feeling it like pierce into the skin, like taking a
Sure.
long time to break there. Yeah, I've always found it to be a sweet spot. So
Yeah.
okay, this leads me to something else I want to talk with you about. So a lot of people, they say they're on TRT, and I've been to a lot of testosterone replacement clinics with clients to speak with doctors, and to be completely honest, the vast majority of men that did join on TRT did not have any clinical issue with their testosterone. So their testosterone might have been on the lower end, but wasn't. They weren't in a situation where they were having testosterone deficiency at that point in time. Some of them, even I would say, a lot of them were kind of in the range you would expect, and it was more of like testosterone optimization therapy, like trying to get them like a little bit over 1,000 and so on and so forth. For clients that come in that maybe they're testosterone, they're not having any kind of testosterone deficiency, but they're still producing an adequate amount of testosterone they do want to optimize. What's the dose that you normally start these clients with?
Well, there's a lot to respond to in what you said. I mean, I could tell you the starting dose I use in 95% of people. That's 60 milligrams of Testi subcutaneously every 4 days. So that's the short answer. But the longer answer is, I don't really optimize. I don't believe in the whole concept of hormone optimization, because it's just a very vague. It's more of a marketing term. What does it really mean? Optimize my hormones. Optimize them for what?
Well,
What does that mean? Does that mean achieving a specific number that is universal, and every guy has to have X number of total testosterone, 1,000 nanograms per deciliter, or whatever? Or does that mean optimizing it for how you feel? Or does that mean optimizing it for your body composition? It's just a term that doesn't really have much meaning, because in point of fact, we don't know what a so-called optimal level of total testosterone is in anybody. If there was an optimal level for everybody, it would be different from person to person, and it would be different even in the same person from one day to the next, depending on what's going on with them physiologically, for example. I've seen guys that are in their 60s who have perfect body composition, low body fat, and, obviously they have no symptoms of hypogonadism, which is the medical term for testosterone deficiency, meaning they have no sexual dysfunction, they have no fatigue, they have no issues with endurance, which, by the way, fatigue and endurance are two different things. And they have no what are called neurocognitive executive impairment. So they don't have poor memory, their attention is fine. They have no symptoms of testosterone deficiency, no classic symptoms. And some of these guys, you measure their testosterone levels, they can come back at like 300, sometimes even a little bit lower than that. And I've seen that most often in guys who are cold adapted. So they do cold plunges, for example. And there's some research evidence that people who are cold adapted can tolerate testosterone levels that are quite low, possibly and probably because being cold adapted has hormetic effects that make it so you're more sensitive to your own testosterone, to put it very simply. Contrary wise, you can have men with normal to even high normal testosterone levels who have many symptoms of androgen deficiency. Testosterone, a number of testosterone, especially in modern society, where you have a huge incidence of what's called metabolic syndrome or inflammatory obesity. There's a lot of middle-aged men with metabolic dysfunction that not only can impair your testosterone production, but also interfere with how the testosterone works, how it's transported, how it gets into the cell, how it interacts with its receptors, how the receptors work, how many receptors there are, variety of things. So, for example, we know that men with metabolic syndrome, something like 40% of adult middle-aged men in the United States, they have a condition of insulin resistance and also leptin resistance as well. Now, I won't get into what leptin is, but most people have heard of insulin resistance. Insulin resistance can greatly impair not only your testosterone production at several levels, but it can also cause what's called metabolic inflexibility inside your testosterone producing cells in the testes called Leydig cells. So if you have metabolic inflexibility in your Leydig cells, not only can you potentially not produce as much testosterone as you need, but you can also accumulate toxic byproducts of metabolism. Okay, your body burns sugar, amino acids, fats for energy, mostly sugar and fats. But if you have metabolic inflexibility, you can't completely oxidize fatty acids, which is a huge problem in the testes because, steroid hormones are made from cholesterol and fatty acids. There are studies showing that these men can develop androgen receptor issues because those toxic byproducts of lipid metabolism can directly damage androgen receptors. So you can have a situation where you have so-called normal levels, but your testosterone just simply doesn't, for lack of a better term, work as well. Okay? You also, when you have metabolic disease, you have low chronic, or what's called low-grade chronic inflammation for a variety of reasons that can interfere also with your how testosterone's transported. It can interfere directly with the testosterone binding proteins. It can interfere with the efficiency and the speed at which testosterone is supposed to work, especially in specialized organelles in the cell called mitochondria. That's actually where a lot of your energy production in most cells occurs. So the long story short is that testosterone levels don't always tell the full story of who can and can't benefit from testosterone therapy. There are men with low testosterone levels that absolutely don't need testosterone therapy. There are men with normal testosterone levels that can absolutely benefit from testosterone therapy. The levels don't always tell you who can and can't benefit in and of themselves. What the levels give you is there's research that's been conducted, both short and long term, in men with specific testosterone levels using specific TRT replacement regimens. And you can say, okay, in guys who had levels of 300, who are in their 60s and 50s, if they go on TRT for this length of time, maybe their insulin sensitivity improves, or their body composition improves, or their sexual dysfunction improves. So it's epidemiological. It allows you to take a patient and say, okay, your levels are this. Potentially, if we put you on TRT based on the results of these studies in men with similar levels, you can expect this kind of benefit. But it doesn't, there are very few studies in guys with so-called normal testosterone levels. But based on everything that I just explained about metabolic disease and how common metabolic disease is, and just how pervasively metabolic disease impacts your androgen signaling, not just at the level of production, clearly you can see that it's not always a reliable, indicator of your overall androgen status. Androgen is testosterone's an androgen, so I'll use those terms interchangeably. I don't know if that makes sense. It's a very long-winded answer, but
No, no, it makes plenty of sense. I'm actually kind of curious. So let's say somebody does come into your practice that is 40 plus years old, seems to have some metabolic conditions as far as like they're overweight, but their total testosterone looking okay, maybe even their free testosterone is looking okay. How are you like figuring out what should we dose? How much dose should we do? Are you just kind of testing and slowly, gradually figuring it out through the practice with him, or
well,
how does
if
that work?
if they get put on testosterone, here's another misconception because you're asking me about dose again. The dose I start people at is usually the same. I mean, it very rarely does it change. It can in some circumstances, but for the most part, in my perspective, especially in someone like you said with so-called normal levels, but who has metabolic disease. So I'm guessing, what do we mean by that? We mean someone who has a lot of abdominal obesity, so they're fat, for in other words, and they have, maybe diabetes or pre-diabetes, high blood pressure, whatever the case may be. The dose that that person starts at is not so much as relevant as what happens with their body composition. So a huge part of my practice I always look at people's body composition when they first come and see me. And that's a big part of the evaluation is, okay, not so much only what your levels are, but can testosterone help with your body composition? Testosterone decreases visceral fat, which is the fat around your internal organs, decreases subcutaneous fat, which is obviously the pinchable fat that you can see externally. That's the type that you can remove with liposuction, and things like tummy tucks and other things, surgical procedures. But the visceral fat reduction is far more important. And that's where you get the most benefit metabolically is by reducing that. Testosterone also increases your muscle mass. It does that in pretty much everybody, provided it's a high enough dose, and especially if you're doing resistance training. And as a result of increasing your muscle mass, and not only your muscle mass, but your muscle strength and your muscle endurance, which are two very important endpoints for longevity, to have high muscular strength, but more so muscular endurance. Some certain patients with so-called normal levels can definitely benefit, and there's some fairly decent research evidence of that. The issue is when you have someone with normal testosterone levels who has perfect body composition. They have low body fat, they have low visceral fat, their muscle mass is normal. That's a person where most likely using testosterone in them is going to be non-medical. And like I said, there are some of those patients, even with low levels with perfect body composition, no metabolic disease, that don't need testosterone. I mean, they have no symptoms. The only symptom, if you could call it that, is the number on their lab is a little bit low. But as I explained to you, there's a variety of factors beyond the absolute number that tell you whether someone can benefit or not. So you really have to do a risk-benefit analysis in every patient, and that risk-benefit analysis should take into account primarily what are the main benefits of testosterone. What are the most likely things that will change in this person? Will it improve their body composition? In most cases, yes, it will. So the question is, can this person benefit from that? Well, if you're a 45-year-old guy who's done having kids, okay, testosterone causes infertility in a huge percentage of men. So you're done having kids, that's not an issue. You're already on weight loss drugs, for example. You already are doing resistance training, for example. Well, testosterone may be highly beneficial in that person, with relatively limited risks. On the other hand, you might have someone who, like I said, they metabolically they're normal and their body composition's normal. It's like what are they really going to get from the testosterone, especially if they have no other side effects that testosterone can help with. Take, for example, sexual dysfunction. A lot of guys end up at TRT clinics because they have either low libido or they have erectile dysfunction. Well, there's no good evidence that guys with normal testosterone levels, so again, the term normal I have a problem with, but everybody knows what that means. It's a normal range. Guys with so-called normal testosterone levels typically don't benefit from a libido or an erectile function standpoint from TRT. So that's one situation where you can use their levels and their specific issues. Those are the only two issues they have. ED, sexual dysfunction, or low libido. Can TRT help that person? Not with the things that are important to them, that they're wanting to fix. Not unless you're using very high doses, okay? There's evidence you use very super physiologic doses that can improve libido. But, you're not going to be willing to do that in someone who already doesn't look like they can have much ancillary benefits. Like, so testosterone's not a treatment for ED in people with normal testosterone levels. Let's put it, if I had to put it in simple terms. So hopefully that makes sense. There's a lot of nuance to this, which is why deciding whether someone should go on TRT is really not all that simple of a process. You have to take into account a lot of things, and especially because we don't know a lot of the long-term risks of testosterone therapy. In men with low testosterone levels and men with normal testosterone levels, we have very limited long-term studies, which is the main reason why mainstream medicine, whatever that means, your primary care doctor, most primary care doctors, endocrinologists, urologists, are hesitant to put people on TRT with so-called normal levels, because there's very much an open question mark as to the long-term safety. So you have to take that into account too. And obviously, long-term safety is an issue, especially if you're younger, because, if you start TRT in your 20s, typically men in their 20s have more time on this earth than men in their 50s and 60s, right? So the risks of testosterone is not just dose dependent. There's also a time dependent risk that you get from androgens even at low doses. That's what it looks like when you look at the research on various anabolic steroids. So that's what it appears. I mean, there's a lot of things to take into consideration. And so it's not just simply what are your levels, if that makes sense. I don't know.
Sure.
That was a very long answer, but hopefully it
No,
was.
no, no, it makes a lot of sense. So I kind of have two questions. One question I wanted to ask you about, I'm going to stick on the same topic first for the second. When you're talking about long-term risks of testosterone, maybe we should talk about that a little bit because, or what potentially could be the longer-term risks of testosterone, because people do it's a little more freely used nowadays than it was maybe like 5, 10 years ago.
Yeah.
So maybe it's good to shed some
Well, I
light
would
on
say
that.
a
What are
lot
some,
more freely used, but yeah.
yeah, I was trying to be nice.
Yeah. Yeah.
Yeah, so maybe we can shed some light on that.
What are the potential long-term
Yeah,
risks?
what are the potential long term? What do we know? What could be a problem? Maybe open up what are some of your thoughts on it generally?
The most likely, I think, if I had to guess, I mean, the thing with all drugs and all medications is even for drugs that are FDA approved in the modern era, okay, a lot of people are taking tirzepatide. Eventually, people are going to be taking retatrutide. These are very popular drugs that have gone through the FDA approval process. Or in the case of retatrutide, is in what's called phase 3 testing. Okay, by the time those drugs get approved, there's still not long-term data on their safety. Okay, and the same goes for 99% of other drugs, including and especially testosterone. So I said that to say, guys that go on TRT today, 30 years from now, are they going to have an increased risk of some weird type of cancer that's slightly higher than what their risk would be if they weren't on TRT for 30 years? Are they going to have a slightly increased risk of strokes than they would if they weren't on it? Are they going to have a slightly increased risks of blood clots? Whatever the case may be, there are a million things that could happen or that could be shown in very long-term trials. Most likely long-term risk that you get from TRT, even TRT doses of testosterone, I think, is there is probably a cardiovascular risk, meaning it may increase your risk of heart attacks and strokes and possibly even blood clots long-term. I don't think it's likely that the risk is very high. I don't think it's likely that in men who are appropriately treated and understand all the nuance that I just explained, assuming they have a good doctor and everything, and you balance the risks and the benefit, the possible risks, I think it's pretty low. Potentially, it even reduces your risk of those things. A lot of people are confused because the FDA recently removed what's called the black box warning on commercial testosterone products sold in the U.S. They said that testosterone carries an unknown, may increase your risk for cardiovascular events. That was based on what are called observational studies that were done, at this point more than a decade ago. Not super high quality studies, but they were the only ones we had. And then in June of 2023, there was an actual clinical trial that was designed to look at the cardiovascular risks of testosterone. That was called the Traverse trial, if people want to Google and look that up. That showed that more or less TRT at the doses used in that trial and that particular patient population didn't significantly increase long-term risks of specifically heart attacks, strokes, or major adverse cardiovascular events. But that was over a period of 2 to 3 years. As you know, most guys on TRT are on it for decades.
Yes.
So that's relatively short term, relative to what the average TRT patient is on it for. And the other thing is the dose and the method that they used in that study, specifically, transdermal testosterone, and at levels that were very, very conservative. That study has limited applicability to most men who are using injectable testosterone, who are also achieving usually much higher levels. So the short answer is we don't know the long-term safety. And the FDA removing that warning was not a statement of testosterone is for sure 100% safe cardiovascular-wise long-term. We simply just don't know. I don't know. Nobody knows, regardless of what these, self-styled experts on social media say. Nobody knows because it's never been studied. But when you look at the anabolic steroid research, which includes testosterone, albeit at higher doses, it's all epidemiologic research. So it's not like there's minimal conclusions that you can draw, like concrete conclusions you can draw from what are called observational studies. But when you look at those observational studies, cardiovascular-wise, there is some kind of risk. And when you understand the mechanism of how testosterone works, particularly on the heart and blood vessels, endothelial cells, you can see that there is, under certain circumstances, a pro-inflammatory effect. And is that a huge effect in most patients? Obviously, it's not a huge effect because men have been on testosterone for 80 years in this country. If there was some huge cardiovascular risk, there'd be a lot of TRT patients dropping dead. It'd be fairly obvious. So I think the risk is not too high, but I think there is a potential risk there. And certainly, whenever you put someone on a medication, particularly if it's going to be one they're taking their whole life, you have to educate them about the unknown long-term risk. And they have to be accepting of the fact that there's a lot unknown about it. But I don't think that testosterone's just has no risks at all whatsoever. It could be men on TRT for 20 years have a 1% higher risk of heart attack every year, or a 2% higher risk of developing AFib every year. I'm just throwing out numbers. I mean, 2% would be low if you're talking to just an individual. I mean, that's actually pretty high. But when you're talking about millions of people,
Oh
that ends
yeah.
up being a lot of new cases of potential issues. So that has to be balanced, right? But when you have a guy with metabolic disease that's severe, that who's already his lifestyle's already been changed as much as he possibly can, maybe he's on some other weight loss drugs, you know, um, a lot of, and that he's middle aged, a lot of times, it's what testosterone does long term to those patients probably outweighs whatever the long term risk is. But can I say that with 1,000% certainty? No, I can't, and no one else can.
Yeah, it's funny. It's funny you said that because one thing I was thinking while you were talking, um, I think that there's some truth. There's a truth there to that at the bottom, and that one of the reasons why I think that people are getting on testosterone because yes, there might be this risk, but there's also this risk of people that do have lower testosterone or suffering from the symptoms of low testosterone
Yeah.
are it's so severe that it one the quality of their life is not at its peak of where it could be at their age, and like them not being motivated to go exercise, them not being motivated to want to have sex and be vigorously moving has a bigger health downside consequence potentially than the upside risk of the testosterone.
Yep. Yep. Well, we know just from studies that being hypogonadal, classically having levels that are below normal, in and of itself is associated with a risk of increased cardiovascular mortality and a risk of what's called all-cause mortality. So guys with low testosterone levels actually die of all causes earlier than people with so-called normal levels. So yeah, that I mean, obviously that's part of the whole risk-benefit analysis thing. Certainly if your levels are very low, there's obviously that shifts the balance more towards probably long-term benefit. And but the other thing you said is actually a separate issue, but I would say equally important issue is the issue of quality of life. When you're 55 years old or older, whatever the case may be, and you have certain symptoms that TRT can potentially help with that are very important to you, like your sexual function, or like your body composition, or like your muscular endurance, cardiovascular endurance, whatever the case may be. There's a certain point in time where trying to improve someone's quality of life is very important, even if there's not a clear answer as to what is the absolute long-term risk. You know what I mean? Some guys, their quality of life is so low that just trying anything is worth whatever the risk is. So you encounter that a lot in prostate cancer, well, not just prostate cancer patients, but really any kind of patient who's had any kind of disease that we don't have good studies on how testosterone affects it long term. So all these things are very complex. I mean, this is why most TRT clinics are just a disaster. You cannot really make an intelligent decision about whether someone can benefit from testosterone or what their likely risk-benefit profile is if, for example, you have a clinic where you're seeing 40 people a day.
Yeah.
I mean, you have 10 minutes to talk to somebody. You don't get an idea of all their medical history. You don't get an idea of all their, what their priorities are in terms of what's important to them. Is this a patient that wants to take a little bit more risk because their quality of life is low? Is this a patient that is very risk averse, in which case, we better be far more conservative? Is this a patient that, for his specific problems, testosterone, there's no reasonably good evidence that it'll help? I use the example of sexual dysfunction and erectile function as an example, So all that needs to be taken into consideration, and it's a very complex, multifaceted process. And can you do that in 5 to 10 minutes? No, you can't. Not safely.
Yeah, I also have seen that, like, in a lot of the testosterone clinics, a lot of my clients that came to me for fitness and exercise, diet, nutrition, so on and so forth, they came to me. The story that I was told was, "Hey, I got on testosterone. I got on, and I kind of was told by the way that I'm not going to blame the doctor because who knows if they just misunderstood. But according to them, the sales pitch was, you're going to get on testosterone, you're going to feel awesome, you're going to gain all this muscle, you're going to lose all this fat," and they just sent them on their way, and they really didn't like tell them, "Hey, you should address these lifestyle changes along with it to make these changes." And then they just kind of thought they were going to take it. And it seems ignorant, maybe, to people that have some knowledge. But if you know absolutely nothing, you walk in and somebody gives you the best case scenario, and then you walk out and you go back, you live your life, which is quite sedentary. You're not moving. The food choices probably aren't the best. You're going to be a guy that has fat that has more testosterone, and you're still probably not going to be feeling your best. And I have like a large percentage of my clients came from that situation.
But yeah, I mean that this is the TRT clinic advertising. They need as many patients as possible on their membership rolls, and they have a revolving door business model. And so, of course, testosterone's a miracle drug. It'll cure your fatigue. It'll make your sex drive like it was when you were a teenager. It'll, make your erectile function amazing. It'll make you have all this energy and endurance that you didn't have. It's basically a supercharged combination of like Ritalin and Prozac or something, And yeah, that's very dishonest. It's very dishonest. It's extremely unethical. A lot of the promises that are made by hormone clinics, so-called, are just fallacious nonsense, not based on anything, purely marketing, highly unethical for sure. And so a lot of guys develop, their expectations are unrealistic. There are obvious cases you can give. If you have a guy that comes in who works a very stressful job, 80 hours a week, and, he has sexual dysfunction or whatever. The thing is, testosterone doesn't fix external factors that make your life, that drain your energy. If you're getting 4 hours of sleep a night and you don't exercise and your diet is like Burger King drive-through before you go to work, and like, for example, when I was a resident, a lot of hospital cafeteria food and vending machine garbage, I mean, testosterone's not going to fix any of that. I mean, you're going to end up with side effects and minimal benefits. That's a fact. So it's not a magical thing by any means. And yeah, that's again why you have to spend a lot of time with patients. That's why I spend at least an hour with every new patient. I don't just look at labs. Okay, Bob, oh, your sex drive is bad. Oh, your questionnaire score on how good your energy levels was low, and your total testosterone levels under 350. Okay, here's some testosterone. We'll see you in a couple months, and all this stuff should get better. I mean, this is why studies show TRT clinics, so-called, have a retention rate of less than 35%, or excuse me, less than 70%. Some of them, around 50%. A lot of patients leave because they're unsatisfied. My clinic, we've lost one patient, and in a 2-year period of operating, just on my own. So expectations are very, very important. giving people a realistic understanding of what testosterone can and can't do, but not just what it can and can't do, period, what it can reasonably be expected to do based on this individual person's situation. You know what I mean? I can say, for example, TRT and the vast majority of patients will help their body composition. Given enough time, it'll decrease their fat a little bit. It'll decrease their percent body fat. It'll increase their muscle mass. Whether or not that's beneficial medically long term for them is obviously, it depends on what is their current muscle mass, what is their current percent body fat, what is going, more important than both of those things, what's going on with them metabolically. You know, we have studies that show that TRT helps men with metabolic syndrome regardless of their pre-treatment total testosterone levels. But obviously, those same studies show the men who benefit the most appear to be the ones that have more metabolic derangement and therefore lower testosterone levels. So all that to say, the ideal patient for TRT, if you could come up with one, would be someone with a combination of metabolic disease, they're obese, pre-diabetic, and or diabetic, and they have hypogonadism. They have testosterone deficiency. Those patients are the ones that tend to benefit the most. Someone who has just obesity but is otherwise metabolically healthy, it's a condition called MHO, metabolically healthy obesity, applies to like 20% of people. Applies to actually, in particular, a group of very old patients that are being studied, you know, for longevity research. They tend to have higher BMIs, be overweight, sometimes even in the obese range, but they don't have any underlying metabolic derangements. TRT is not a treatment for obesity, just period. Okay. TRT is a treatment, in my perspective, and based on thousands of hours of research, for people with testosterone deficiency, classically, according to what the usual guidelines, and potentially for certain patients with metabolic syndrome, where their testosterone levels don't necessarily determine whether or not they could benefit. Outside of those indications, you know, just obesity. And no, it's not appropriate for that. For depression, I have depression. Is TRT the appropriate treatment? Rarely, almost never, unless it's accompanied by, unless we think that the depression is part of a larger, you know, situation where where androgen deficiency is causing or contributing to it. You know, and all of this has to take into account the individual's their individual risk factors and their individual priorities. You know, a guy who's 65 and can barely function with testosterone levels that are borderline but still technically normal, you know, he fix me, doc. Do something to make my
Yeah,
life better. That's a different situation than a 28-year-old who wants to build size in the gym. Does that
for
make
sure.
sense?
Oh,
Yeah.
100%. 100%. And I think that even if you are the guy that maybe testosterone isn't the necessarily the right medication for you, but you want it to gain size or anything else, I think that if you are going to do it, and very importantly, to get somebody that will monitor your blood work with you. Don't try to like be a self-diagnosing doctor and check out what you're going to be doing. Like, go with a doctor and talk with them, and make sure that if you are taking this excess risk, you're fixing all your lifestyle factors to get the most out of it that you're going to get, because you are taking a bit of a risk. How big that risk is, you know, like we said, we don't know, but we're taking some form of risk. So make sure that you're doing everything you need to do to get the most out of it if you're going to take that risk.
Yeah, absolutely. I agree 100%. That's part of the reason why at my clinic I have a lot of I have a screening process for people that I take as new patients. I don't take everybody that fills out a patient interest form on my website, because my business model is not I need to get as many patients on testosterone as possible. That's never that never has been and never will be. But I try to select for patients that already have the lifestyle component figured out a little bit. Because, for example, resistance training, weightlifting. If you go on TRT and you don't do any form of resistance training, your benefits from TRT will be nowhere near as good as they would be if you did resistance training. Medically speaking, definitely. For example, there are studies that I've talked about on my social media recently where they've given guys TRT without resistance training and compared it to a group of TRT with resistance training. It was only the TRT with resistance training patients that actually had any improvement in their muscle endurance, cardiovascular endurance, and even muscle strength. Now, all groups, even TRT alone, their body composition improved a little bit, but you got way better benefits with the resistance training. But more important than that, you got the ones that actually matter for longevity, which would be your endurance and your strength. Okay. So, yeah, that makes complete sense that if you don't have a lifestyle modification, right? Let's just say that, then yeah, I mean, you are obviously since you're getting less benefit from the drug, that means that the risk side of the component it balances that scale more towards risk. So what you
Yeah.
said is correct. Maybe I said that in a much more convoluted way, but that is true, and the other thing is, why do I do that? Well, there's a hair transplant surgeon in Mexico that only does hair transplant surgery on patients that have been taking drugs for hair loss for at least a year. And the reason that he does that is because, as a hair transplant surgeon, you can imagine a lot of your business is going to be determined based on like other patients having good outcomes, based on how good the pictures are on your website of people. Okay, they came in, their hair loss was really bad. Then you did the surgery a year later. Look at their beautiful hairline, type of thing. Well, he knows from studies that patients who take the hair loss medications will have better outcomes. Therefore, he only wants to deal with the patients that are going to have better outcomes.
Yeah.
Does that make sense? So,
Perfect sense.
so for him, his reputation is dependent on outcomes, just like mine is dependent on outcomes too. But we want to pick the patients that are going to have the highest chance of success. Patients that are just like, here's the other thing. Whenever you go to the doctor for whatever problem you have that's subjective, whether it be pain or fatigue or whatever the case may be, usually it's pretty unrealistic to go into the office expecting that this pill or this injection is going to be the thing that just fixes everything. You don't have
Yeah.
to do anything other than just inject this medicine once a week, and your life in every domain is just going to get better. And all your fatigue is going to go away. You've probably met people who have those expectations. Those are
My,
not realistic expectations.
yeah, most people, to be honest, have that expectation. It's funny. I run. So I've mostly focused work on people that are taking GLP-1s for most of my clientele. Um,
Even
that
those
is
drugs.
it's the biggest. To be honest, like so many clients I have that they're like, in the beginning they lost 10, 15 pounds and then their weight just stalled. And
Hmm.
then they're like, what's going on? And it's like, I'm sorry,
It's not a
Cindy, you're only,
mystery.
yeah, you're walking 1,000 steps a day. Like, you can't not move and inject this. It's, eventually you're going to catch up. There's going to be a balance. Sure, you're eating half the amount of food, you're moving even less now. If you want the weight to come up, we need to start adding in these other variables that you would do with regular weight loss. It's
Correct.
what I tell people: GLP-1s, testosterone, whatever you're taking, and some I have some clients that are on plenty of other substances as well. They're taking a lot more anabolics than that, but
Sure.
I'm like, whatever you're taking, whatever the reason is you're taking, you can't expect the baseline, which is you got to train, you have to eat right, and that right and train is subjective depending on your goals, obviously. Like training right for some people could be, getting 7,000 steps a day and doing resistance training twice a week. Well, for somebody else, it's getting a 6 day split, going close to failure and eating, 230 grams protein, just depending on your goals and what your reasoning is. That baseline doesn't change. These drugs just enhance the process that we're dealing with and the results that we can get from it.
Yep. 100% agree. I agree with you 1000%. And everything that you said. Yeah, and yes, a lot of people do have unrealistic expectations. And, it's part of a larger issue just in our society where people think that every problem has a simple solution, and that's just not true. Usually to reverse metabolic disease, some people want to say obesity, oh, it's a disease of discipline. When you're undisciplined, you become fat. I think that's way oversimplifying it. There are complex hormetic and obviously genetic, but mostly hormetic, circadian, lots of biologic reasons, especially in our modern society and in our environment, that promote, increase the risk for metabolic disease. And so I don't think it's really simple enough to say just get disciplined and, I mean, first of all, we know that typically doesn't work. I'm just
Yeah.
diet and exercise. I mean, that's just the outcome studies are not good for that alone. But that aside, that does not then mean, therefore, that lifestyle isn't a important component of improving those things. It absolutely is. And yeah, so that's what you see with the GLP-1 drugs. If you don't, by the way, what's the most important exercise with GLP-1 drugs? Is it running on a treadmill or getting a desk treadmill that you walk on for 8 hours a day at work? No, it turns out that it's resistance training. Why? Because those drugs reliably cause most people to lose weight, assuming they can get to an adequate weight loss dose and tolerate side effects. But they're also highly associated with muscle loss. What do we know about when you lose a lot of muscle with a lot of fat? Well, you lose your muscle mass, you lose a huge component of of your glucose metabolism. You slow your resting metabolic rate. That's not good. You don't want to lose a lot of. You want to lose fat and preserve muscle, at least preserve muscle, preferably increase it, particularly if your muscle mass is low. But that brings us roundabout to where TRT can help even patients with so-called normal testosterone levels. What does testosterone do very effectively in many patients, particularly middle-aged men with metabolic disease? Helps them preserve their muscle mass, especially when it's coupled with resistance training. That's why these GLP-1 drugs with testosterone work very, very well because they have synergistic effects. One's a very potent fat loss drug. The other's a very potent, at minimum, muscle preservation drug. So you get the lifestyle component right, it's like a third, a third major factor that you're putting, in that's going to help you have a favorable outcome, especially long term.
I agree 1,000,000%. We're on the same thing. Like people don't understand that the less muscle you have, the lower insulin sensitivity you have, and that could be a bit of an issue. Like, and if when they're losing weight, especially if they're taking GLP-1s and they're not changing their lifestyle. I have a lot of patients that were on TRT and then they got on like semaglutide originally, now tirzepatide, and retatrutide is like slowly coming up now too, even though it has in phase 3, but people are getting it from peptide clinics and whatnot.
Mm-hmm.
The difference with what they're seeing coupled with resistance training and proper nutrition guideline is like fantastic, the results. But Doc, I want to ask you one more question before I let you go because I don't want to keep you for too long. But this is actually a personal question, so I'm curious of your opinion. So I've been on TRT for about 2 years now. Within those 2 years, I've realized something. I originally started with a dose. I was taking about 125 milligrams testosterone cypionate per week, and my testosterone went really high. Like I would do a blood test basically 7 days after I took my dose, and my test would still be like at 1,300. I started at 1,200. That's when I got. I know. So I started at 200 when I started testosterone. That's where I was. The doctor thought potentially it was because of head trauma. I was a professional fighter for many years. Um, and even though I was young, I was 35, 30, yeah, 36. Well, I'm old now. When I got on, I was, he was like, yeah, your testosterone's really, really low. We did multiple tests to confirm that, it wasn't just a freak outlier test. And it seemed to be the case. It was like 300, 250, 200. So I got on, and over the time I lowered the dose, we basically went from 125. I went all the way down to 75, and at 75, I'd be around like 800, 850 within the week again. And it seems like I'm a pretty slow metabolizer of testosterone. Do you see that people have different the way they metabolize testosterone throughout the week? Is it different between people? Do you see different patients metabolizing it differently?
Yeah. Yes. Definitely. Absolutely. Yeah, and especially if you do intramuscular, it can be very unpredictable. So that's why you test people. I mean, that's why we do labs every 3 months. Yeah, everybody's different, and it's not. See, that's why I was telling you the starting dose for me for most people is the same because it's not the dose you start at; it's how the dose is adjusted. And I mean that could it will require a whole nother series of podcasts to explain my approach to that. But the short story is, yeah, I mean everybody metabolizes it differently. There are guys that, for example, there are older guys that are on low doses of gel testosterone that get really good body composition effects from even just moderate doses of transdermal testosterone. There are other patients that require higher end doses of injectable testosterone. So yes, it's absolutely it's different for every person.
Yeah, I'm curious if that like something to do with liver function, why the testosterone is metabolized quicker or slower. I'm curious why some
It
people have
has to do
different.
with a lot of things. I mean, yes, liver function indirectly because your liver function determines the level of your binding proteins that bind free testosterone. That would be particularly SHBG, sex hormone binding globulin, and albumin. And there's some other very minor ones that aren't even worth mentioning. But yeah, so indirectly, yes, it can affect your testosterone milieu, liver function. More directly, it has to do with certain things in pharmacology, like we call it volume of distribution, how much concentrates in the tissues, how fast it's released from the depot. There's a lot of factors, so many that it's not even you could sit here and list a million of them. But yeah, I mean, your liver function can certainly be one of those things.
Yeah, it was something that I was like I didn't know if it was a something that I should be alarmed of or not because I was like I'm getting like right now. I switched from Cibinate to Enanthe, and when I did, I made a bit of a calculation error. The Enanthe capsules came in um, 250 milligrams. So I poured it into like basically a vial because I only take 100 milligrams. But I pulled out zero point 0.5 because my Cibinate was 200 milligrams instead of zero point 0.4, and I shot it in. And then a week later, I took my blood test. I didn't even realize I'd made this calculation. My testosterone was like at like 1350 or even, yeah, I think it was 1370. I think it was 1370. And
Mm-hmm.
I was like, that's way higher than it's not insane, but still, I'm normally at like 950 to 1,000 at 100 milligrams, and I'm like, I wonder if I'm having any kind of liver issues. Is this why I'm getting such a high dose after 7 days? It's still getting still getting that much of a high dose.
No, everybody is different. It does just because you get high serum levels, whether at peak or at trough, meaning right before your next injection. So in theory, that would be the lowest level. So if you inject weekly, every Monday morning, and then check your levels a week later, Monday morning before you do the injection. Yeah, some people can have higher, some people can have lower, and having higher or lower is not necessarily an indication of disease per se. It's just more, everybody's different. I don't know what to say. The thing, yeah, I mean that's why you have to check people and follow up with them, and do their labs on a reasonable time scale and do it consistently. And obviously, levels are not the only thing that you look at. They're definitely not the only thing I look at. I mean, obviously, at any given dose, if someone's having side effects that are really problematic, things need to be adjusted. In other cases, if they're not getting certain benefits, the dose may need to be adjusted. Yeah, but the answer to your question, I think, is can people get different levels from different doses? Of course.
Yeah, I had I actually haven't had many side effects, thankfully. My For a while, my lipid profile was a bit wacky when I first got on testosterone, and it never really had been before. But I basically changed up some diets. I took some supplementation, not medication, just supplementation. Started taking a fiber supplement, cleaned up that, some more omega 3 fatty acids, and everything now is perfect. But outside of that, thankfully, knock on wood, we've been good.
Yeah, what I would encourage people to do is just make sure you get a good doctor. A lot of these TRT clinics don't know what they're doing, unfortunately. So you got to be very careful. But having a good doctor who knows what they're doing is a good way, I think, to minimize harm and maximize benefits. Both of those are very interrelated issues because obviously, if you don't maximize benefits, then all you get it really is risk, right, and vice versa. So that's really an important thing. How people get the most out of TRT is starting with having a very educated healthcare provider.
Yeah, I agree, and that's one thing I try to do the best. I actually got my test back yesterday. I have a meeting with my doctor. I think next week. I was like, I'll get ready, but
Yeah.
then we got on the call, so I was like, okay, I'm gonna throw it out there on the last question. I was like, I'll catch it. I'll leave it for the end. But
Yeah.
Doc, I really appreciate your time. Thank you for coming on. Thanks for sharing all this knowledge. I'd love to have you back on so we can get
Sure.
even more into the weeds with everything. I'm gonna
Yeah.
link your Instagram in the bottom as well.
Thanks. Yeah. If people want to find me, I'm also at b3clinic.com. So, but yeah, thank you for having me. Appreciate it. And hopefully it was useful. I tend to give long answers to simple questions. Um, so I blab a lot, but hopefully people found it useful.
I found it very useful, and I'm sure people did. Like I was locked in the whole time. I've been writing notes on the side here every chance I get. So thank you
Yeah.
so much. Appreciate you
Thanks.
again, guys, and hopefully we'll be together again, and we can keep this conversation going. That's
Yeah,
the
my
pod.
pleasure.